I'm Don Yearsley. I'm an occupational therapist here at Northwest Neural Behavioral Health in Meridian. And I've been an OT for about 7 years now. So I'm happy to be here and talk with you today. So today I'm just doing the basics of what is the role of occupational therapy with kids with autism, especially those under the age of 5. So to start out, we're going to go over today, like what can OT address with kids with autism and neurodevelopmental disorders? What does an OT evaluation look like? What do our intervention sessions look like? And then when should you refer someone to get OT services? With autism, we all know that can result in difficulties with communication, social skills, restricted interests or repetitive behaviors, sensory processing, motor skills, and those adaptive behaviors. So if I want to go to the next, yeah. So for what does OT address? And I really liked this little quote because it just kind of is more so concise. So we often focus on enhancing the children's sensory processing, their sensory motor performance, social behavior performances, self-care, and participation in play. In older children, we might focus on more social and behavioral performances of transitioning to work and independence in the community. But we definitely work on transitioning in younger kids as well. But it just looks a little bit differently. Where can you get OT? You can get it at the NICU, you can get it in the infant toddler program, which was talked about today, developmental preschool, outpatient clinics, and I think there's even like a home health company out there. I think it's called Kids Care that's starting to do like OT in the home, even if they're not like super medically complicated kids. So that's a great resource as well. So yeah, there's lots of places that they can get occupational therapy. So with kids with autism, most of them tend to have motor developmental delays. Excuse me. In this study, they found that 91% of the children with autism were considered developmentally delayed for their gross motor skill performance, and they needed early supportive interventions. Which that was higher than I expected. But there's lots of studies out there that agree with this finding as well. So definitely motor development delays is a key for this. So next slide, please. Sorry. So what do we work on is we work on kids with autism. They perform poorly with imitating tasks. They have a hard time doing those social and communicative behaviors like eye contact or verbalizing what they need, like was in our case earlier today. They have a hard time using tools, whether that's in the classroom or at home. So that could be like using a toothbrush to brush their teeth or brushing their hair or even just playing with toys, using those different things. Sorry, I had a pop up, excuse me. They struggle with performing those activities of daily living, getting dressed, eating, and performing those instrumental activities of daily living, which is, are they able to get a snack if they need it when they're a little bit older? Are they able to meet those needs? Adaptive behavior, they have deficits that oh my gosh, excuse me, my words are hard today. Excuse me. So occupational therapy is trained to address toileting, mealtime behaviors, whether that's actually eating or even just being able to stay at the table for a full meal and participating. We work on other cares of self-care, like washing your hands, brushing your teeth, taking baths, tolerating that. Helping with household chores as they get a little bit older and age appropriate. Participating in leisure activities. For kids, that is play, right? That's their job as a kid, is to be able to play. So we work a lot on building those play skills of whether that's that joint attention or even just interacting with toys. Some kids just have no interest in interacting with toys. And so just teaching them how to play with those different things they come across. As they get older, we start working on handwriting. And even in these younger kids, we work on drawing those pre-writing shapes, like, circles and squares, because those are going to help them be able to be better with their handwriting as they grow and develop, and all kinds of other areas as well. So what does an OT evaluation look like? Typically, for us in our clinic, they're about 1 hour in length. It varies. Some clinics do a little bit longer ones, but that's what we found works best for us. We ask that the parents come back. If that's not available, we'll call them or talk to them at a different time, because we like to have them come back so we can get a better history of what's going on, be able to ask more questions, and that kind of thing. We usually do some kind of assessment. With our younger kids, we usually do like the Peabody, or we do the MFUN, which is the Miller Function and Participation Scales. But there's all kinds of assessments out there, but that looks at the fine motor and the gross motor, their fine motor and gross motor assessments to look at in those kids. And it just gives us a good overall picture of what this child's like, how are they able to, how is their fine motor skills, or if there's some deficits. We also usually do a sensory questionnaire. There's a lot of different ones out there. Typically, you'll see it's the sensory profile or it's the sensory processing measure, and they're relatively similar. They both go through all the different sensory areas, and they can answer questions, and it gives us a better idea of where those different sensory concerns might be. And then we also just use observations. Some of these little guys, especially like the kiddo we talked about today, probably wouldn't sit for an assessment. I wouldn't want to do any of the activities. And so we would just use our observations and just try to interact with them and just see if we can get them to do any kind of activities, just to get an idea of where they're at. So individual sessions, typically you'll see a weekly session is 45 to 60 minutes long. I worked at a clinic. I did briefly that did 30-minute sessions. I personally prefer longer sessions. So I'm glad that at my current office, we do a little bit longer sessions, because I think it just gives it time for the kid to transition into the session. You can do some kind of sensory warm up and work with them, and then get them to work on some other activities before it's time to leave. Those shorter sessions, sometimes you just don't have enough time. But the length of whether I choose 45 to 60 minutes also depends on the kid. Some of my younger kids, 60 minutes is a little bit too long for them, so we shorten it a tiny bit. But we work on parent education and training them, talking to them a lot, and addressing their concerns. We do a lot of task performance and interventions. So working on those different skills, whether we're modeling them or helping change those things. We work on, like I said, coloring, holding things with our hands, playing with toys, sitting and attending to a task, even if it's just for 1 minute, sometimes with kiddos. We do a lot of sensory stuff to work on those sensory concerns, and just give them the help that they need. An example would be if a 4-year-old with autism came in and had problems with like adaptive and fine motor skills delays and increased behaviors, we might work on toothbrushing with them. We might work on pre-writing shapes and getting them to even maybe just scribble. Sometimes that's the first step, is just getting kids to scribble with a pencil or a pen. Sustained attention to play, or getting them to do a non-preferred task. That's probably one of the biggest things we work on, because kids don't want to do things they don't like to do. So that's hard. And then that self-regulation piece, finding out what will help that child. For our younger kids, they often don't know what will help them. So working on figuring out, oh, the swing's really calming to them. Okay, let's work on trying to get a swing at home, or maybe they really like a squishy thing, or they like vibration, whatever it is, to help with them self-regulate. So when they get upset, they can calm down easily. Other OT interventions that we do, we work on, like I mentioned before, that play-based approach, and helping them work on trying to interact with us and other peers. In our office here, there's other therapists in the room, so that gives them a chance to interact with other kids their age, and to work on those social skills. We work on social cognitive skills training, so that social emotional skills, work on social stories. I love using social stories to help teach different things, whether it's like why we don't hit people, or if there's a change in their routine. A lot of kids with autism, we know, are very rigid in like certain schedules and routines. So when that changes, it's very confusing to them. So social stories are a great way to be able to introduce something that's coming up, whether it's a doctor's appointment or going on vacation, or whatever that is. I recently was talking to a parent, and the little girl was a little older. She was 6 years old, but the mom had told me that she just couldn't grasp the concept of summer. Like now that when school was out, she just didn't know what that looked like, what was going to happen. And so we had to work through helping her understand, like, yeah, like you're not going to go to school and things like that. And then sensory integration and those sensory-based interventions. So we do a lot of messy play with occupational therapy. A lot of kids with autism don't like having their hands messy. So we work a lot on getting them used to that. And that looks a lot like I think I talk about this later, but we don't just throw them in with like a bunch of paint and be like, we slowly work up to it. So we might work with more drier textures first, like let's play with them in the corn bin, or we have a thing of sand, and then slowly work them up to some more wet textures to help them become more tolerable with those different sensory inputs. So sensory differences in autism. One study found that 39% of children with autism were under responsive, 20% of children were hypersensitive, and 36% of children show kind of a mixed pattern of responses. And that's what I typically see. Most children that I work with, they have that mixed different sensory differences. So on the next slide, oh, I thought it was a chart. That's the next slide. Okay, this one, how do we assess the sensory differences? Like I mentioned before, we do sensory questionnaires. We talk to the parents and ask them. Sometimes the parents don't actually know what they know. I'm sure you've learned that until you start asking questions, and then they're like, "Oh, well, I never thought about it." But you're right. He doesn't like um, I can't think of an example, XYZ. And then you're like, oh, that's probably because of this. Typically they do know the ones like the loud noises or don't like their faces getting wet. They don't like their hands getting dirty, that kind of thing. And just observing them. I have a little kid that I currently see, and he's definitely a visual stimmer. Throughout his session, you always see him looking out of the corner of his eye, and he'll hold things up and move them around. And every session he finds something new that he likes to look at. So I'm like, yep, he's definitely love that visual input that he's getting from those items. Like light up toys, he just loves them because he just likes to watch everything, and it's very, very calming to him. Next slide, please. So here's the chart I was thinking of. So with sensory, we kind of are able to put them in different categories. Are they a sensory seeker? Are they an avoider? Do they have low registration? Where did this child land? And in all the different areas, they could be different. For movement, they could be a sensory seeker, right? This is the kid that's always running around. They love to jump and crash into bean bags because they like that input. Sometimes kids even like will crash into a wall. They love hugs. They just want that input, and no matter what they do, they're never going to have enough, right? If they have that high level of sensory seeking. I think of it as like if you think of their different sensory areas as cups, they have a big cup, and no matter how much water you're putting in this cup, how much sensory input, it's never going to get full, right? They just are constantly wanting it. They just love it. We have those that are really sensitive. Those are the kids that don't like loud noises, right? They cover their ears. They might notice sounds that nobody else notices. I have kids that can hear like a clock ticking, or the sound of the air conditioning on our treatment room bothers them, and they're always like, "What's that? What's going on?" So they're just very sensitive. You have the avoiders, like I said, mentioned with the different sensory inputs. They don't want to touch it. I one time gave a kid kinetic sand, and he immediately just like pushed it away and like turned around. Like he didn't even want to look at it. He didn't like it. And then you have the low registration people as well. And they're the ones that they just don't get that sensory input. So it actually takes a lot more sensory input before they kind of register what's going on. And so that's also something you have to work on, is if they just they just don't pick up on as much as other things. So that's when you get the kid that might not hear what's going on in the room, right? There could be all this commotion going on, and they just doesn't register that they're hearing those noises and things like that. Next slide. So how do we address these sensory differences? I kind of briefly talked about it a little bit earlier, but there are some environmental changes you can do. That's not always easy, but if they're overwhelmed by a lot of things in a room, so maybe have a playroom for them at home that doesn't have as much stuff, right? They don't need every single toy in a room. In classrooms, it's not as easy to manipulate classrooms, but if there's not as much distractions in an area, that can also be calming. Predictability, warning them, helping them to know like what's going to trigger them. For a lot of kids, they don't like to go into public bathrooms because of the automatic toilets, right? They don't, it's jarring to them. The sound's hard. Sometimes it goes off without them expecting it to go off. They don't like the hand dryers. And so giving them a warning and walking them through that and helping them is very helpful. Hey, I'm going to turn the blender on, or we're going to do this activity. Start slow and build. That's what I was talking about earlier with like the wet textures. Is I'm not going to take a kid and force him to touch a bunch of paint and do finger painting if he hates that. We're going to start slow, like let's play with the other things and slowly work our way forward. Um, I had a kid that was terrified of hair dryers. Like it didn't even have to be on. It just looking at it, she would start to cry. And so for a while, we just kind of hid it away, and then slowly we'd kind of leave it out. I wouldn't have it in like an obvious place. And then she slowly kind of got used to it. And then after a while, she didn't cry when she saw it anymore. She still doesn't like the sound of it, but at least she's able to see it and not have a big reaction. um, Teaching them an appropriate escape from a non-preferred activity. We don't want them to learn just to run away every time something bothers them. So you can teach them things that might help them, whether they ask for a break and go somewhere else, or, for those younger kiddos, having like a calm corner or a place they can go that they know that they like, or helping them know that they can have like their noise canceling headphones or something like that if there's going to be a loud sound. We do a lot of sensory-based intervention, and it's hard with research because it doesn't always say that it's effective, but having used it, we know that it is effective. So even though it's one of those areas that definitely needs more research to prove it, but we definitely know that through occupational therapy that these sensory-based interventions are helpful to children, and we see a lot of progress with that. Next slide, please. Regarding the sensory processing disorder diagnosis, SPD, a lot of parents ask us about it. They think their kid has it. And the American Journal of Occupational Therapy, I like what they said. It says, we choose to describe the problem rather than the name of the disorder. So we recognize that kids have sensory processing difficulties. It's a term that's not in the DSM-5. So we can't officially diagnose anyone with it, but when parents come to us and say, we think our kid has SPD, we just kind of acknowledge it and say, we recognize they have a lot of sensory processing things. We agree with you. Let's just work on addressing those. And also occupational therapists, we can't diagnose any kind of thing like that anyway. So when parents are looking for that diagnosis, we're like, we just can't provide that for you, but we agree with you that your child has sensory needs. Next, please. So what is sensory integration? So there's a specialty called the IRIS sensory integration. It's not part of a curriculum or qualification. You can get like a special certification in it, but we do learn a lot in school about like the entry level of sensory integration. So the latest review is of some of the sensory integration is like strong evidence in the Qigong massage, which when I read that, I was like, I have never used that before, so I might have to look more into that. We know a lot about modifying the environment is very helpful. There is limited evidence for weighted vests, which is interesting because a lot of people use them, and I have seen benefits with them. But I recognize that a weighted vest isn't an answer for every child, which I'm sure you know as practitioners is every child's different. So I have seen some success there. I used to work with a kid that a weighted vest was very calming to them and they liked it. And so it worked for them. I will say a weighted vest is not meant to be worn all day, every day. They're supposed to be worn in short increments of time. So I think sometimes parents think that they should just wear it all the time because that they like that heavy input, but it should mainly be like 15 to 20 minutes and then take a few hours break. But as I mentioned before, there's insufficient evidence for swinging and multisensory activities. However, having used them, I recognize that they are very useful. It's interesting. Different kids have different reactions. So swinging back and forth to some kids is very relaxing. Spinning in a swing is very relaxing to some kids, whereas spinning in a swing to other kids might actually give them more energy and kind of rile them up and cause other problems. So I've learned which of my kids I can actually let spin because it'll calm them down, or those kids that I'm like, we're just going to swing back and forth today and have that be our calming thing. So when should we refer to occupational therapy? Whenever you have concerns with the fine or visual motor skills, and even if it's nothing blatant, but you're just kind of like, oh, it seems like they're struggling with that, or maybe I feel like a kid should be able to do that at that age. We're happy to assess them and see if there is a need there. Um, Adaptive skills, if you realize like they're getting older, they can't help, they're not helping dress or they can't get dressed on their own. Maybe they just can't take their shoes and socks off, that kind of thing. Oh, it's okay, you're good. Thanks, Lindsay. Um, if you notice those sensory differences, like in our case study today, he had all kinds of sensory things going on. Like, so I'm happy to see that he got a referral for occupational therapy. School participation in handwriting, and in even in those kids that are under the age of 5, we're starting to look at handwriting, right? Like, are they doing their pre-writing shapes? Are they even interested in scribbling and things like that? And in more and more as they're starting to go into preschool and kindergarten, they're expected to know their letters. So working on that and forming them. Sometimes that formation of letters is really hard for kids, so we work on that. And being able to sit at desks for a long time, that's all going to be part of it. So that attention to tasks. Feeding and oral motor concerns, we work on that as well. Feeding therapy is very important, and I'm happy to hear that that was also recommended for that little guy. So working to be able to increase those preferred foods that the child will eat and those oral motor concerns. And it's important to have them get assessed because sometimes a picky eater, they might be picky, but they also might be picky with what they're eating because they don't have the oral motor skills needed to be able to eat the food. So like for some kids, if you've noticed, they all like really soft foods, whether it's like chicken nuggets or bread and that kind of thing. Maybe they don't have like the skills to to bite off the food or to chew it properly. So they want those softer foods that they don't have to work as hard for. So it's just always good to have it checked out so we can make sure that there isn't an oral motor concern and then focus just on that feeding preference. And quick side note about feeding therapy, it looks different depending on who's doing it. Here at NNH, we do feeding therapy and we come at it from like a sensory approach. We use the SOS approach to feeding. And from that angle, we don't ever force a kid. We're not going to say, you're going to take 3 bites of this and then we'll move on to another food, but we want them to get used to it. So we kind of come in where they're at and then we work towards it. So it might be just getting it used to on their plate or in the room. And then slowly we get used to them touching it and then interacting with it and eventually get them up to hopefully, well, they're going to actually eat it and try it. And another thing to remember, I remind my parents is, granted, we that this like in our case that he definitely had a feeding concerns because he had like less than 10 preferred foods, but sometimes parents will come in and be like, well, they don't like this, and they'll give me a specific example, and that's fine. But sometimes there's just things that kids don't like to eat, and I remind them as adults we have our foods that we don't like to eat, right? So we're not every adult likes every food they eat, and that's okay. So we want kids to learn to like all foods, but recognizing that sometimes they might just have a food they don't like. And then we also work if there's any concerns with behaviors or self-regulation. We definitely work on that. So we work on not like being okay when things don't go their way, doing non-preferred tasks, work on limiting those meltdowns that they might be having, and work with the parents to kind of come up with ideas and strategies to help with that. As they get older, we can work more with the kid on being able to use the tools on their own. When they're younger, a lot of times it falls on the parents. So we work with the parents to help to teach them what tools and things they can learn at home to eliminate some of those behaviors. Um, just in closing, sorry, I feel like that went really fast, but um, occupational therapists are skilled at assessing and treating children's sensory processing, sensory motor performance, social behavior performance, self-care, fine motor, executive functioning, and participation in play. So basically, I tell families, I'm like, we pretty much do like all of it. It's just a very broad area of things that we can cover. And so never hesitate to recommend someone to come to occupational therapy. We are always happy to talk with families. And even if we've even had a few families come to us and be like, I don't know why we were referred, but someone thought it would be helpful, and we figure out together why we think occupational therapy would help them. And if it turns out that it's not a good fit, then that's okay too. But then they'll at least have an idea, know, oh, my child actually is where they should be with their fine motor skills, or oh, actually, these are the things we can be working on. So yeah, thank you. You have any questions for me, or I don't know.
Don, thank you so much. It was time for us to have an entire session dedicated to OT. So let's open up to questions, and we have a couple minutes. You can unmute or put those in the chat.
Don, this is Preston. I have a quick question. Some patients we want to refer for maybe play therapy for emotional dysregulation issues. And I'm wondering about the overlap, play therapy, occupational therapy, or if there are certain of those things that would fall more along with occupational therapy versus just behavioral issues that as they get older, we would think more of counseling type of therapy.
Yeah, that's a great question. I think that kind of complements each other a lot of ways. Most of our kids kind of do both. Um, and there is some overlap going in there. Um, I think it's beneficial. They each have their place. Sometimes, um, like I'm trying to think, as they get older, we might tend to have them like if the kids like old like I said, as a kid ages, we might have them to more counseling, depending on it what it is, because what we find with occupational therapy is we teach them a lot of tools, and but then sometimes they have a hard time actually applying those in their lives, and so sometimes counseling is good for to be able to help them actually start to implement those tools when they're younger, like in that 5 and under range, because it just kind of depends. I'm sorry. I guess that's not a very good answer to your question, but it's kind of a by case basis what we usually do. I wouldn't be afraid to refer them to both of them because I think they each kind of work on things from a slightly different angle. I guess it would be occupational therapists. We tend to come um, in at an angle from like sensory stuff like that. So we kind of come in like, okay, let's do these kind of things to help eliminate. So they're head banging. Can we get them input in a different way to eliminate that head banging? Or this they're getting super angry. So what can we do to kind of eliminate that? Whereas I think sometimes with counseling, it can kind of help. It helps with those areas, but then it comes off it from like educating parents and helping them work through those things and helping the kid as well. That wasn't a very good answer.
No,
I
that helps. That
apologize.
helps. Thank you.
Yeah,
That helps.
Travis, do you want to chime in?
Uh, Don, can I add to your answer there for a second?
please.
I know you have some therapists in your office as well, like some mental health therapists as well. I think that collaboration, Dr. Omar, between OT, speech, counseling, PT even, that, triad, quadrad, is amazing. I mean, amazing. If your parent and the consistency and collaboration between all those providers becomes solidified, like that patient's progress is beyond just each one of those individuals. And in a lot of the ways, I always think of like you have these circles and we overlap, like speech and counseling. I've got communication and OT and skills, and we all have our overlap. So there's definitely, as Don was saying, kind of a not one patient specific that meets all of those, but yeah, I would not be afraid to send them out to those services and that allowing them to collaborate with each other. Go ahead, Dr. Harlan.
Real quick, I know we have like 1 minute left. I actually had a family bring this up to me this morning. Child had been in OT for a while. Child is now well into school age. And we were talking about like pivoting to doing like CBT intervention for really high anxiety and OCD like symptoms. And so I think you bring up a really good point, Dawn, and that sometimes certain interventions are more needed than others. I do think that OTs are more easily accessible and readily available. Especially for young kids, you can get in sooner. I think teaching some really great strategies for calming and regulation are wonderful. But then psychotherapy, a good psychotherapist is going to address some parenting strategies and coaching for addressing behavioral issues in kids, and then and also encouraging the use of those calming strategies as well that OTs will recommend. So anyway, yeah, I agree. But I do think, if you're going to start with anywhere, if they're on a wait list for PCIT or parent management training, you can still refer to OT too, because I think OT could be able to address some of the kind of concerns maybe faster But the team, I think, is a really good approach.
Real quick, I think, we often prioritize the speech, the feeding, the OT. Oftentimes I'll get messages from the OT saying, I think this kid would benefit from a PT evaluation, right? Because of, slightly low muscle tone or discoordination, toe walking that might need to be addressed with orthotics. So if you get those messages from your OT, make the referral, get them into PT, just because they are also part of this interdisciplinary team. So Travis, thanks for kind of starting the conversation on that.
Wonderful. Thank you so much to all of our presenters today. Love the conversation. We're going to meet again September 12th. It's a shortened time on the 12th because our STAT cohort will be having a meeting following. So it will be from 12:30 to 1:30 Mountain Time. The topic is role of the speech pathologist in working with children with autism, presented by Jamie Piper, our panelist, Don's lovely coworker. So we hope to see you on the 12th of September. Take care. Thank you. Bye.